Really exciting. All of the 20th year festivities at ISIS are already beginning. But of course, the truly exciting news today is our presenter, Dr. Thien, who received his bachelor's degree in health sciences from McMaster University in the year 2005, an MD degree in medicine from the University of Toronto in 2009, an internship in residency training in radiology ongoing at the U of T. As well, he is a commissioned investigator trainee, as well as an MSc candidate in clinical epidemiology. So today is a little bit unusual, right? Today is a stage 2 thesis proposal, which means that the candidate speaks in an uninterrupted manner for 20 minutes, followed by questions and answers, hopefully for 10 minutes. And then after that, everybody who is at the rank of assistant professor or above in any department, in any university, including you, Matt, stays behind. So for a whole bunch of us, it's over in about 40 minutes. Okay? And without further ado, we're all yours.
Thanks for the great introduction. It's a great privilege for me to be here today. And as you can see, there's the title of my presentation. So we're going to talk about intracerebral hemorrhage today. So intracerebral hemorrhage encompasses about 10 to 30% of all strokes, and it's the most deadly and disabling type of stroke, with little improvements in mortality over the last 20 years. There's a 30-day, 30 to 50% mortality, and only 20% of those patients regain functional independence. And because of this is all associated with high health service costs. Interestingly, it was once thought that intracerebral hemorrhage was a static event, but it's now come to be demonstrated that hematoma expansion occurs in 1/3 of patients within the first 24 hours after ictus. So you can see here from this diagram or this figure that the patient here came in at 5.2, and then an hour and a half later they've got marked intracerebral hemorrhage expansion with intraventricular hemorrhage, and the majority of this occurs in the first 3 hours. It's been found that this hematoma expansion, as demonstrated by serial CT scan, is associated with early neurological decline and poor long-term outcome. And this association between hematoma expansion and poor long-term clinical outcome has made this an ideal target to prevent hematoma expansion. If we can prevent that, then we can prevent the poor long-term clinical outcome. So this is studied in 2 randomized clinical trials. One trial is investigating hemostatic drug to see if we can clot off this hemorrhage and then that way reduce hematoma expansion. And the second was acute blood pressure reduction. So a lot of these patients come into the emergency department, they have high blood pressure, you try to reduce it, and hopefully that will reduce it. And fortunately, both these studies demonstrated a reduction in hematoma expansion. Unfortunately, the main point was that there was no difference in 3-month poor clinical outcome. And we have to wonder why that is the case. So, and this highlights the need for patient selection. So, as we know that 1/3 of patients only 1/3 of patients will undergo hematoma expansion, non-selective treatment of all ICH patients results in dilution of the clinical benefit expected to only be 1/3. And on the other side, factor 7 specifically is associated with increased risk of arterial thromboembolic events. So those 2/3 of patients are getting the risks associated with treatment. So this really highlights the need for improved patient selection for treatment. And this is where the SPTA spot time comes in. So this was coined at Sunnybrook by Dr. Richard Aviv's lab. And it's basically shown here. You can see this patient comes in with an intracerebral hemorrhage here, and you can see this little dot of contrast leaking out into the hematoma. And there's a radiological definition for this, but basically this sign was strongly associated with hematoma expansion. And this was recently studied in a prospective study, PREDICT trial, which is the data for my thesis, which I'll go into later. But the sensitivity specificity was 63% and 90% respectively. So you can see that it's fairly specific, but not overly sensitive, and that's where some other factors can come in to improve that sensitivity. You can see that it also had an effect on mortality with the age-adjusted mortality hazard ratio of 2.4%, which was statistically significant. So selective targeting of treatment to those most likely to undergo hematoma expansion may lead to demonstration of clinical efficacy. And this is currently being studied in 2 randomized clinical trials. The Stop It study and the Spotlight study, where they're randomizing patients who have a spot sign to hemostatic therapy. And Stop It's in the US and Spotlight's in Canada. On top of this, we hypothesized that a clinical prediction score incorporating 3 or more clinical laboratory or radiological variables may add a further predictive value for identifying patients at high risk for hematoma expansion and poor outcome. And ultimately, what we want an accurate and objective scheme to estimate the risk of hematoma expansion in acute ICH to allow patients to be stratified for future clinical trials. The current problem is that there's only a single radiological score to predict hematoma expansion, and that only incorporates the spot size. So it looks at the spot number, the spot size, and spot density. But as we've seen, that the sensitivity is not that great itself. So further stratifying it by these characteristics is only going to improve specificity, really, than sensitivity. And another problem is that multiple ICH scores exist for predicting death and poor clinical outcome. The most widely studied is this ICH score by Hemorrhage in 2001. But if you actually take a look at these scores, there's a lot of methodological flaws. A lot of them are retrospective. Their sample size is only about 200 maximum. I mean, this is a problem for our PREDICT study, which is the problem for a lot of radiological studies. But at least these ones are retrospective. Their lack of blinded assessment is also a problem. And there's also a poor comparison between the scores to determine which one is best. And none of these scores ultimately incorporate this CT spot sign. So after my literature review, you can see that there's a lot of potential risk factors for hematoma expansion and poor clinical outcome and death. And a lot of these variables here are incorporated in those spots, these ICH scores. But I won't go through that. But they're both clinical, radiological, and laboratory. And so what we then, as we move forward to make our score, let's reflect on what makes a good score. So firstly, it must have rigorous development methodology, both in terms of the study design in which the data is derived from, and which means that there's blind assessment of the predictors and outcome. They're reproducible predictors. There's more developmental methodology. But ultimately, we want improved prediction over general physician estimation, and this will lead to buy-in. It needs to be clinical sensibility. It needs to be user-friendly. You can't spend a lot of time doing complex computations. And it must be easy to remember, so things like Glasgow Coma score, APGAR score, things like that. So ultimately, this leads to the master's thesis objectives. So firstly, we would like to develop 2 separate clinical prediction scores, incorporating all these aspects, including the CTA spot sign, to risk stratify patients for 1, hematoma expansion and poor clinical outcome. On top of this, as we have this beautiful data sitting in front of us, it would be nice to validate and compare the existing scores, both for hematoma expansion and poor clinical outcome as well, to see which one of them performs the best, and then also compare our score with those. And the ultimate goal is to facilitate prognostication and guide future clinical treatment decisions. We hypothesize that this clinical prediction score, incorporating the sign, will demonstrate high discriminative ability for predicting patients at high risk of hematoma expansion and poor clinical outcome, and that this score will be better than other scores for hematoma expansion and poor clinical outcome. So the data set for my study will be provided by the PREDICT study, which enrolled patients from 2006 to 2010, and approval for performing the study was given by the PEI and the PREDICT study collaborators, and research ethics approval has been obtained. So let's talk about the PREDICT study. So the objectives of the PREDICT study was to validate the single-center observations in a prospective multi-center study with blinded evaluation of hematoma volume and CTA spot sign, and that's the beauty of it. It was to establish the sensitivity, specificity, as well as the predictive values of the CTA spot sign for predicting hematoma expansion and poor clinical outcome. It was so there were 12 centers in 6 countries. The inclusion criteria was 18 years or older, and you had to have intracerebral hemorrhage confirmed on CT within 6 hours, and of less than 100 milliliters in size. As intracerebral hemorrhage is demonstrated to be, for sure you're going to do bad when the hemorrhage is very large, which may require surgery and things like that, and that's why the limitation is set for the 100 milliliters. The exclusion criteria were renal impairment, because you'd be contraindicated to have CTA. Pre-morbid and modified Rankin scale of greater than 3. The reason for this is because a lot of the time in intracerebral hemorrhage, it's thought that people do poorly because there's early withdrawal of care. And so to eliminate that factor, we want to choose people who are doing relatively well beforehand. Also, as all intracerebral hemorrhage studies, you want to eliminate any other cause of intracerebral hemorrhage, secondary to ICH, and you also want to remove people who have a GCS score of less than 4 or major terminal illness for the same reason as the MRS. The PREDICT study variables collected were all those basically listed in the associated factors for hematoma expansion and poor clinical outcome. And so all the known risk factors being, as the PREDICT study collaborators were very tuned to what the risk factors were, they collected all of those. And the most best part of the PREDICT study was that it collected the CTA data, which is very rare to find. And it calculated actually the time to get to each of those imaging time points. And also what makes the PREDICT study great is that there's blind measurements for the ICH volume measurement. So those were measured using a computer software at the University of Calgary. And the calculation of hematoma expansion was independent of the spot size interpretation, which was done at Sunnybrook. The study outcomes for my research project will be for objective 1A, with the primary outcome would be 24-hour hematoma expansion, which would be the calculated difference between the ICH volumes on the CT scans, as well as the secondary outcome of death or poor outcome, defined as the modified Rankin score greater or equal to 5 at 3 months. So this is just an outline of the dropout and the patient number at each one of those levels. So you can see here for objective 1A, we ultimately had 228 patients from the 268 patients enrolled. And that's because a lot of patients, or a few patients, received factor 7 treatment. Some died before the CT scan. 15 had surgery, which was mainly EVD insertions, and 4 had just no follow-up done. And then for objective 1B, there's 176. So there's a few lost follow-up, and a few 55 did not meet the follow-up criteria. So these are limitations of the study, which we'll talk about. But then on the other side, we'll include those 7 who died before, and include those who had surgery for the final outcome. Here's some numbers, just roughly, in terms of consideration for the statistics. There are 73 patients who had hematoma expansion for objective 1A. And for objective 1B, there's 80 patients who had the poor outcome, with 54 patients who died. So then we move on to the statistical analysis, which is a big part of this project. And this is all guided by the Harrell and Staderberg textbooks. And so firstly, as with any statistical analysis, you want to clean your data to make sure that any extraneous or inappropriately typed numbers are cleaned. You want to then categorize only continuous variables only as clinically relevant. As we know, categorization of continuous variables can often result in a loss of data. So then, because the Interact 2 trial, which is basically just follow up with Interact 1, their target treatment area is blood pressure between 150 systolic and 220. So then we'll kind of categorize that, as well as GCS with those categorizations there. And this is because the GCS score has been found to be unreliable in certain instances. So we want to make it broad categories with the outliers identified so it's easier. And in terms of the univariate analysis, we'll just kind of take a look at that in terms of screening using the appropriate tests based on the data type and normality. What's really the crux of this project is the multivariable regression, which can be difficult in a limited small sample size of 200 patients. So what we'll do is we'll take the whole cohort for the derivation. We'll then perform a logistic regression for each one of those outcomes. And then the variable selection strategy is for prediction and parsimony. And we'll try to follow that 1 to 10 rule to ensure that we're not overfitting. And then the selection of variables is based on, number 1 at most is subject knowledge. Number 2 is measurement reliability and accuracy, and number 3 is distribution. So if there's any missing data or the data skewed to one end of the spectrum, then we may not include that. Grouping and selecting of variables. To reduce the items, we'll group them and select only one from a certain domain. So, for example, level of consciousness was recorded by both the NIHSS score and the GCS score. And we'll also reduce items by detecting any multicollinearity. And then ultimately, at times in my literature review, the univariate association, it's bad to select things based on their p-value on the univariate association. So we'll try to limit that at the 0.2 level. In terms of then, once we have our variables, how do we know which model is better? So the way we're going to do this is by just examining which one variables may be more accessible, face validity, measurement reliability. We'll use the AICs of the models to then compare between them. We'll use nested models to determine if that variable is significantly influencing the outcome, and we'll ultimately use the C-statistic and calibration at the end to make sure everything fits okay. Then how do we get to a score? So once we've done our logistic regression, we'll end up with beta coefficients, and then often what times this is done is they'll divide by the age-related coefficient, or by the smallest coefficient. So, and then that way you get an integer value, hopefully. And then from there, because we have a small data set, we may need to provide some kind of shrinkage to make sure that our data set's not overly optimistic. And some people use a linear shrinkage model, but can be a very complex topic. And then following this, ideally you externally validate this, but what you can do is internally validate this by performing a bootstrapping to ensure that the statistic is stable, so that it doesn't drop terribly. And then also, to ensure that we have the right variables, what we can also do is bootstrap stepwise selection, but that is kind of a secondary consideration. Finally, for objective number 2, the comparison between the scores, what we'll do is then assign the appropriate scoring methods to these patients. Compare those scores based on their ROC curve and C statistics. So there's statistical methods for that, and we'll just perform that. And then also what we can do is on top of that, we can evaluate the methodology used in those scores in a systematic manner, and that's been described below. And ultimately, we want to have something that's going to be simple for people to use, so that's going to be the ultimate test. So this study is limited by several factors. The first and foremost is probably the sample size, but as with any imaging study, this is going to be very difficult. These are not 1,000 sample size where everybody has a CT angiography. The intracerebral hemorrhage is also not very common compared to ischemic hemorrhage, so that's probably why. And this was 12 centers. So we're doing fairly well there given the limitations. There's also missing data, as you saw that there was inappropriate or incomplete follow-up for several patients, so that was also a limitation. And there's also a lack of external validation in this study, but in order to remedy that, there's ongoing trials right now which are recruiting patients with CTAs. So then as we develop our score when they get the data, then we can stratify it and also externally validate or come up with a new score at that time. So in summary, intracerebral hemorrhage is a devastating disease with high associated healthcare costs. Risk stratification score is needed to identify those highest risk for hematoma expansion and poor outcome. Incorporation of the CTA spot sign with clinical variables is expected to improve prediction of hematoma expansion and poor outcome. The clinic data is the best, most rigorous data we have in terms of radiological data. And validation and comparison between scores would be very helpful in driving future clinical use. The results of these studies could have a significant international impact and help address an important problem. And in terms of, for myself, as a master's student, the project is feasible and represents a great learning opportunity, both in terms of the methodology, the score creation, statistical analysis, and just general appreciation for future design of future cohort studies in radiology. And then these methods are readily applicable to future projects. And that's pretty much it.
We are slightly ahead of schedule, so that we will reward you with a few extra questions. First question to David.
Nice presentation. Is the spot sign a predictor, or is it almost an outcome because it's on the causal pathway? It's analogous to me to the early days of upper gastrointestinal endoscopy when we saw a bleeding vessel in the base of a deep ulcer. And sure, it predicted bad outcome, but it was actually causal, and we then went in and cauterized or injected those vessels. Is this not a blood vessel just spurting contrast, and it's really an outcome rather than a...
Yeah, exactly. It's not like a true... That's what my impression is, but there's been some editorials about this as whether it's a biomarker or the outcome itself. The histopathology of the spot sign is not well understood. It's very difficult to get tissue. We did recently published a case report of this where we saw a dissection in a wall. Sometimes people think they're fibrin globes. It could be just frank bleeding too, but it's not like we're not seeing it, right? Like you're seeing the vessel there. So it could be for sure. Nonetheless, I think it still represents an attractive therapeutic target, just like you're cauterizing that vessel. It's still, whether it predicts in an indirect manner or a direct manner, it still predicts, I guess. So.
Okay, Peter, you're next.
You said that one of the criterion for assessing a predictive model should be its simplicity, that it has to be easy to apply. So how many of the neurologists or radiologists that you interact with, how many of them have iPads, Blackberries, and Android devices of some type?
I don't know that.
Right, okay.
Yeah.
So
1 out of 1.
Most people have, most physicians have access to some sort of smartphone.
Sure.
So why does anything need to be simple? Why not just have an application where you punch in 6 things and it says this patient's probability of having an adverse event is 25%?
Oh yeah, absolutely.
So why is simplicity, is it better to have something that's complex and performs well, or something that's simple but performs less well, given modern computing?
I mean, if you don't, what happens if you don't have an iPhone? You're in a rural area or a tertiary, secondary care center. I think, that's been the standard established before there was like iPhones, and I don't think that it's, we can expect everybody to have iPhones. So ideally, it'd be simple, right? If you don't have time when you're at the bedside making these important clinical decisions, you're not always going to think to leap to your iPhone and do these things, right?
So let's go to the other extreme.
Yeah.
So let's take the Framingham model for predicting cardiovascular events.
Right.
Let's say you have a 55-year-old male who's, give me some,
Hypertensive, diabetic, smoker with elevated
Brown
cholesterol.
shirt.
so what's that person's 10-year risk of cardiovascular events?
Oh, I actually, yeah, I mean, it's tough for me to calculate right on the
So
spot.
there you have a simple score.
Yeah.
In theory, that's a point-based scoring system. It uses 5 or 6 variables.
Right.
But for it to be really practical, you're either going to have a sheet in front of you where you're going to tally things up, or you're going to have some sort of an app.
Yeah, definitely.
And so I'm not sure that simplicity is necessary.
Yeah,
If people aren't memorizing the Framingham rule,
yeah,
are they going to be memorizing your rule?
right. I mean, at least the model should be parsimonious, right? I think that would be ideal, right? We shouldn't be sticking every single variable under the sun. But granted, there is some complexity that we can have because we have these, these things probably should be scored on a sheet of paper or an iPhone. So I do see your point that we can allow some complexity, right? But from a statistical standpoint, should we include every single little detail that, is going to add a little bit of predictive value? Probably not, right? So, but I do see your point, yeah.
All right, Matt, I think you're next, and then Brandon.
So, nice talk, by the way. I'm a little concerned about the generalizability of these cases. I mean, nobody's in this room is going to argue that ICH is not a bad disease, but I think if I caught the numbers right, 50% of this cohort had a poor outcome. A poor outcome was MRS of 5 or death. So, a fate worsened death and death itself is your outcome.
Yeah.
So, that seems higher than a lot of the data on ICH prognosis in the literature. So these seem worse than most ICH patients or not?
I mean, some people say that 50% die at 3 months, right? So there's personally, from my understanding, I don't think it's that bad. And actually, I think it's better because they sub-selected out those patients who had a terrible GCS. They sub-selected people who had huge hematoma loads. So I actually think it's better because some of the literature that I read is 50% mortality in 30 days, right? This was 30% at 3 months, right? So I was wondering that myself, what cohort is this representing? So I think it's actually the better cohort. I don't know about if it's. I think intracerebral hemorrhage is a terrible disease. I think that's what they were seeing, but I think that's representative. From my understanding, but I don't know.
So you think that these numbers match other contemporary cohorts of this disease right now? I mean,
Yeah.
a lot of problems you go back 10, 15 years ago data and things seem to change a lot.
Yeah.
In medical treatment of ICH.
Yeah, I would argue that it's the better subset actually. And I think realizing that there's a big improvement we can do.
Okay, Brandon's
Just
next.
to follow up on Peter's question about prognostic models, will the data that you are eventually fall out of the model you'll be using, will that be available in the future to people on the front lines? Will the data be available?
The data for the missing patients?
Whatever you're predicting.
Are we going to publish that data?
No, is the data going to be available?
Oh, for the mission? Yeah, it is available. Yeah, it is.
Routinely?
Yeah.
And they're generated in real time and people can use them?
Yeah. I think, are we on this? I'm not sure we're on this.
It's not just going to be age, they're just going to be the scan results.
Right.
Clinical variables that may be in some database in some hospital.
Oh,
that may
yeah.
not be available at the website.
All the variables collected here were clinically used. So this was not stored in some retrospective data set. This is your blood pressure when you came in. This is your INR when you came in. This is the CT size when you came in. And it's not, is that your question? Yeah, it's not like calculated later, or somebody had to peer through the charts, for, this is prospective stuff, so it's good.
Next question back to David.
Can we rise to a higher level again and ask why this is important? I mean, it seems self-evident, intuitive, that knowing who's going to have an expansion of an intracranial hematoma is important, but is it really? In other words, is the probability of that event going to influence your treatment in some way, a drug you would administer, or a procedure like evacuation of the clot that you would undertake?
Yeah, I think you could argue that, for example, blood pressure reduction, this has been discussed, that maybe you should just treat everybody anyways, right? There's really no point. But especially if you're going to give something that has a harm to it, right? You want to have for example, your CHAD score as well as your HAS-BLED score for treatment, anticoagulation treatment with atrial fibrillation, right? So I do see a point in selecting that. You're trying to find that 1/3 who are going to have hematoma expansion. I don't see any point in giving a clotting agent for if you're already 24 hours out, it's a stable size, you're going to have a heart attack from that. So I think you do have to make a decision if you're going to treat and not treat, and I think this is probably the best marker of that. Does that make sense? Or would you add anything, Dr. Leslie?
Yeah, no, I would agree. And also the potential for surgical interventional trials that are underway and being planned. We can foresee future treatments that might rely on this type of stratification, right? Because roughly 2/3 of patients have stopped bleeding at the time of their initial scan, and they're not going to get worse due to ongoing bleeding. And you can then say that they're likely to remain clinically stable, not get worse, and then there would not be a strong indication to subject that patient to either aggressive hemostatic investigational therapy or go to the operating room for specific stereotactic removal of the clot or other interventions. So I think there is a potential future role for selecting patients for treatments. There currently is no proven acute treatment for intracerebral hemorrhage. And but I think even more broadly applicable is just to improve our ability to accurately prognosticate, right? Because when we're in the emergency room consulting on a patient, our current methods for predicting that patient's prognosis in the first few hours is imperfect. And so I do think there is a need to improve the ability so we don't have an overly pessimistic prognosis for the patient. I mean, we routinely see survivors of ICH come back for their 6-month and 12-month follow-ups in our outpatient stroke clinic, and it would be good to know how to predict the patients who can have a good outcome, and rehabilitation candidate and so forth. So that sort of leads me to the question I was going to ask you, and you kind of mentioned this right at the beginning of your talk about withdrawal of care, right? And this may be a limitation. I wonder if you've had a chance to think about this. There seems to be a tendency in ICH in general to have early DNR orders written, and withdrawal of aggressive care in the ICU. And in the ICH literature, it's been talked about a lot, this so-called self-fulfilling prophecy, right? So you have a patient comes in with an acute hemorrhage, and you expect that they're going to get worse, and and then the care is not maintained in an aggressive fashion and withdrawn, and that may be a key determinant of the early mortality.
Yeah.
In many of the patients. And so how can you take that into account?
Yeah.
And I mean, that might be even more important than the imaging marker or other clinical factors, right? Because you don't have a standardized protocol where everyone is, treated aggressively for a certain duration of time in a standardized fashion.
Yeah.
Right?
Yeah. So I mean, I would have two comments for that, really. I mean, I am limited by the way they performed the study, but I think they did think about that in the study with their inclusion-exclusion criteria, right? If you were so far gone, or you're going to have for sure a poor outcome based on the indicators by the ICH score, for example, then those people would be eliminated. But that still doesn't, I can't say for certain that there would be some early withdrawal care because that variable was not collected. So it is for sure a limitation. On top of that, though, I would just say that even just studies validating the ICH score, you can see that when in the multiple studies that were prospective studies that were validating the ICH score, which is composed of GCS, intracerebral hemorrhage volume, basically variables that did not have palliative included. They all performed very similarly across in like different cohorts, so like Argentina, Brazil, things like that. So it did stratify without palliative care. So, but who knows? I mean, it is a big problem, and I know there were several papers that did show it's one of the biggest predictors of dying after intracerebral hemorrhage. So it's hard to, if anybody has any ideas on how to get around that. One thought I had is, again, just to take it a step further, I think it's out of the scope of this study because we just didn't measure it, but to look at the registry data to see how many patients are actually getting palliative before they get in the hospital or after they get their hemorrhage, to understand a little bit. I think given those limitations, this is the best.
Okay, last succinct question to David Neymar.
So just a comment and a quick question. The comment is, I think parsimony is important. Clinicians have a very limited tolerance for entering anything into anything. Okay, so an iPhone app is great, but if it has 10 elements, I guarantee you that people won't use it. So I think parsimony is important. The question is, emerging as a methodology for comparing predictive models is reclassification. So classifying into meaningful risk categories using one method, and then reclassifying using your new method, and then calculating statistics about the potential benefit of correct reclassification. Have you thought about using that as a model metric?
Statistics is all very new to me, and this is why I'm doing my master's. So I'll have to bug you for that. I think you've just bought yourself some teaching time. No, I'm just kidding.
Okay, all right, and we will end on that point. Thanks very much, Dan.